So what you're gonna learn today is what you would do with a patient, but there is a little bit of modification. You're not going to do the vaginal rectal exam on the patient, okay? So there's a few modifications because, I mean, she has to do a pelvic with every one of you in one day, so there's just some things that are not gonna happen. But this is what you will be doing on every one of your patients that need a well-woman exam or come in with a gynecological complaint. So, and I will show you the equipment that you need to perform this, okay? I know you guys have had a lot of this information already about when and why and what, right? Does this not work?
It might not be on.
You'll be broken.
What? Who broke it?
Alex did it.
We're just gonna reschedule. I can't work without this thing. Is the battery dead?
Like as a joke.
What?
Let's do it tomorrow.
If I would have thought about it, I would have done it.
Just for texting or? All right, exactly, okay. Okay, so what you need to think about, obviously, when you interview a patient is, you know, we talked about things that should go in the review systems or the HPI. It kind of depends. So we'll take a review of systems on a patient who comes in with, you know, abdominal pain, and part of your review systems will probably be the pelvic. But if someone comes in with pelvic complaints, or they're in for their well-known exam, you're going to put that within your HPI. Or if I do have someone with abdominal pain, I probably will put in my...
That was just my phone.
Are you interpreting me?
No.
It sound like different language or something? I'm speaking, I think, your language, maybe not. But if I do have someone with abdominal pain, I probably would include in my HPI about pelvic stuff, or GYN stuff, or obstetrical stuff. But to do a complete review of systems, you would absolutely ask these questions, even with someone with chest pain or cough or congestion, or I'm admitting them to the hospital. So, you guys know about abnormal bleeding yet? Have you had that lecture? No? Have you had that lecture? Oh my God, some people are not. You're saying no.
Well, only for pregnancy.
Okay, so you haven't had abnormal bleeding yet?
No.
Okay, so some of the things you need to ask about is, okay, so how often do you bleed? I bleed once a month. So how long in between your periods? So is it 28 days? Is it, you know, every other month? So those are some frequency. And you also ask is, when you do menstruate, how long do you menstruate for? So normal is about 5, 6, 7 days, okay? How heavy do you bleed? So, and they're gonna say, oh, I bleed normal, or I bleed heavy. And you have to quantify that. So you ask the question is, do you use tampons or pads? Well, I use both. Okay, so well, on your heaviest day, which is usually day 2 or 3, it can vary. How many tampons do you use? Okay, so for people who don't know this, most women use and change their tampon about every 4 hours. Okay, but some women will say, I have to change my tampon every hour. And with that question of a tampon, you have to ask what size they use. So there's different sizes of tampons. So the next time you go to the pharmacy, this is for the men mainly, who aren't married or have a girlfriend that they've had to go buy their tampons. Go to that section sometime. Don't be embarrassed. Just go there. You can act like you're buying incontinence pads. I don't care, but it's the same section. And you go and you look, and there's slim, there's regular, there's super, okay? Because that'll tell you if they're going through a tampon every hour, super, you know their flow is heavy. Some people use pads. How often are they using their pads? And are they using the maxi pads? And they're overflowing it, okay? So ask about those things. And the type of flow, so if they're bleeding real heavy, do they have just kind of a normal flow, or do they have a lot of clots? Because that's significant. Okay? If they're postmenopausal, are they having any bleeding? I haven't had a period in 5 years. Well, have you had any bleeding since then? Because that's significant, because you want to make sure that you found that out, because that person needs a biopsy, because you always have to rule out endometrial biopsy, or cancer. Okay? Do they have any pain when they menstruate? So most women do have a little bit of cramping, but this is severe. I miss 2 or 3 days of work, 6 times a year. Well, that's a lot. Okay? When's their pain the worst? No? I don't know. Okay, so.
The laser was working. Was, I thought.
That's gonna help me.
I'm just saying, maybe something with a clicker.
Oh, see?
It's just amazing, the slides, I'm trying to connect it.
Was it the battery?
Alright, that's fine. Okay, so when is their pain the worst? Is it actually when they menstruate? Some women will have premenstrual cramping, so a few days before. So what medicines do they take for it? What helps? Vaginal discharge. So always ask about vaginal discharge. Women are embarrassed to talk about it. Some come in for vaginal discharge. Ask about odor. Okay. Some discharges, we have normal physiological discharge. It's worse in sometimes it's more during our menstrual cycle. Okay. Color of it, the consistency of it. You need to ask these questions. You just got to do it. Okay. What's their sexual history related to it? Okay. Do they have any pain associated? If they have discharge, do you have any pelvic pain? Okay. Premenstrual symptoms. Okay. Headaches. Okay. Mood swings. Breast tenderness. Okay. Menopausal symptoms. So you need to ask the onset. You know, when do they start having kind of irregular bleeding? How do they feel? A lot of women start having vaginal dryness, sexual issues. They don't want to have sexual intercourse anymore. They don't feel good about themselves, so you got to talk about that. When did their mom go through menopause? Because that'll kind of help you have an idea of when they're going through menopause, or if this is menopausal symptoms. Okay, their infertility history, urinary symptoms, you guys should already know what to ask about that kind of stuff. That would be coughing, sneezing, do they lose urine, all that kind of stuff. Okay, when did they start menarche? Okay, when did they start bleeding? Why is that? Cancer risk? You guys remember this? You guys had a test question on this, I think, didn't you?
We probably knew it like 4 hours ago.
Breast cancer risk? Okay, so women who have longer exposure to estrogen, okay? So if I have my period early on, I'm exposed to higher levels of estrogen, so that puts me at higher risk of breast cancer, right? If I breastfeed and I have babies, guess what happens to my estrogen levels? They go down, so I have lower risk of breast cancer. Okay? So those are things that you can talk about. You guys should know the obstetrical history. Okay? I mean, know that, just learn that. You'll document it 6 million times. And their gynecological history. So, when's the last time you had a PAP? Was it abnormal? Was it normal? Have they had HPV testing? Did they have any gynecological procedures? Anything like that? Okay? These are things you ask. All right. Okay, so you're going to do your breast exam. So there's 3 positions that you actually want to look at the breast. And the reason why is if you put a patient in 3 different positions, you can actually get pathology by stressing the ligaments of the breast. So the first thing you do is you have them put their hands up, okay? The next position is have them put their hands on their hips or kind of behind their back, okay? And then the next one is you just actually have them kind of lean forward. So that stresses the breasts a little bit, it puts them in different positions, and you actually may see like dimpling of the breast or an indentation of a breast that you wouldn't have seen before. It also allows you to see under the breast a little bit when they lean forward, because you have big pendulous breasts that will really kind of lay on the wall of the abdomen even, and you need to see that. And even when they lean forward, if you can't see it, you may actually have to lift it to look at it. Okay? So that's the 3 positions that you really want to put a patient in. Again, as we talked about with the male GU, it's patients naked, right? And they're uncomfortable. These are private areas to them. That's why we call it the privates, right? To kids, we talk about those things. So the best way to kind of alleviate is use this time to educate your patients. So kind of talk to them and say, kind of what I'm looking for is skin coloration changes, rashes, anything that kind of, both breasts should look similar. If you see something abnormal, you can bring it up. So patients will have different size breasts. Okay? This is a normal thing. If you've ever bought a bra, you always know one's not quite the same as the other. This bra fits great for the right, but not for the left. So you got to find a bra that's perfect. Guys, you know this too, right? So anyway,
I don't know. Got called out.
But what you need to actually say, if it's really significant, is actually bring this up. Because one, it may be a significant mass has developed in that breast, or this has always been something for this patient. And I will tell you this, sometimes it's a big deal for that patient. They're like, it's always been like this. I'm embarrassed. I don't go work out in a gym because I don't ever want to get undressed. I don't go to the ocean. I don't go to a pool because I can't find a top that I can wear out in public. And it becomes a big deal. So I had a young girl who was 18, 17 or 18, I think she just turned 18, but she was fully developed, and she was an A and a C.
Holy crap.
Okay, so this can happen. There was no cancer, nothing like that. But think of being in high school or being that age where she had this problem. So her and I talked for, I was in the room for about an hour. And she was a beautiful girl. Beautiful, beautiful girl. And she had such self-esteem problems. She was depressed. She was starting with a little bit of eating disorder problems. And so we talked about it. And I ended up sending her to get breast reconstruction on one of her breasts because that's not fun to live like that. And it was never going to develop all of a sudden. She was already mature, and so you have to talk about these things. So it's going to happen. Okay. If you see a rash, ask about it. Women will have different nipples than maybe you've seen before. Nipples can be inverted. Okay. You have to ask if it's a new thing or it's always been like that. Because a new nipple inversion can be pathological. I mean, it could be a problem. There can be pathology that has pulled that nipple in. So I was asked, your nipples are in or inverted. Has that always been like that? Yes. And they may just have one. Okay. So you have to ask the question. All right. So there's certain skin disorders that we can have. You'll the breast, at the top of your differential has to be cancer, okay? It's usually not, but you have to put it there. Because I have seen Paget's disease missed in 2 people. So it's usually this female is put over-the-counter ointments on it, antifungal, and it just doesn't clear it up. Or they've gone to a physician or a PA or any type of clinician who's just like, put the cream on it, put the cream on it. But any rash on the breast should be followed up in 2 weeks, always. Okay? Now, it's very common to get yeast around the breast. Why? Because our breasts are here, they hang down, they touch the skin, it sweats, especially this time of year, and fungus, yeast loves moisture, and it stays moist. Okay, so it's common to get it underneath the breast. That's another reason to always ask about diabetes in your well woman exam, okay? Because, one, they're higher risk of endometrial cancer, but they're also at risk of getting yeast infections, both vaginally and underneath the breast. Okay? About all this. There is something, I've actually never seen it, but a supernumerary nipple, which the line, you can actually, as we develop, you will have a supernumerary nipple, so don't think it's a mole. It actually can develop nipples down this line. For mammals, it happens. It's not an abnormal thing. It's just, don't be taken like, what is that? Okay, nipple discharge. Let's talk a little bit about nipple discharge. Always ask about nipple discharge as you're doing this exam. Have you ever had a nipple discharge? What you want to ask specifically about the nipple discharge is when it happens. Okay, what is the color of it? And if it's bloody. Okay. So bloody discharge is a significant finding for cancer. Of this that I'm talking about, probably a really great question to find out and do, test to do with someone who has nipple discharge. Always do this test to work up nipple discharge. A pregnancy test. Kind of the #1 cause of nipple discharge. So if you find nipple discharge, and they're not pregnant, right? Because you can have nipple discharge all the way through a pregnancy. What you do is you do a cytology on it. You can take it, take a swab of it, put it on a slide, and send it off to see what those cells look like. Then it multiple times. Part of your breast exam should always be to check the lymph nodes. Okay, there's cervical chain here, supraclavicular, and axillary. Because remember, lymph nodes, one by itself isn't significant, but remember chains, especially multiple chains together. And make sure when you get in there, especially in the axillary region, get underneath that pectoralis muscle. So, the best way to do a breast examination is first have the patient sitting. They're already sitting there anyways. But as they're sitting there, It's kind of like you're doing a mammogram, but you kind of pancake the breast. Because the breast tissue, as it comes forward, you can actually grab the breast, the patient sitting here, and pancake that breast to look for any masses that is in that breast tissue. So kind of put your right hand left underneath it and kind of feel for any nodules, masses, anything that feels abnormal. You could walk to the other side of the patient and then just kind of flip your hands and do the same thing. You don't have to flip your hands, but that's what's recommended. You do it the same way, it doesn't matter. Okay? It really separates that breast tissue off the wall, the chest wall, and you can really get it's a great technique for pendulous breasts. Big breasts are hard to do an exam on, and that's a really good way to get that breast tissue examined by palpation. Okay? Next thing you're doing is you're going to lay down. Okay. So you have them lay down, and whatever breast you're doing the exam, so the right side, you have to put the right arm up. What that does is allow you to get to the tail of Spence. This breast tissue goes all the way up here. And it pulls that breast back and allows you to get to the chest wall. And as you palpate the breast, you use, obviously, your finger at the tips like this, right? You use the pads of your fingers, and in a circular motion, as you're palpating each area, you kind of go in a circle, kind of superficial and then deep into the chest wall. And you cover the breast either in a circular motion. You can do it up and down to cover the breast. You can do it like a bicycle spoke, with spikes or whatever those are called. I don't know. But as it goes out like this, there's a picture of it. Like a wedge here. What's that technique? What that means. But you have to make sure you do all of the breast tissue. Breast tissue goes down into the axillary region, so don't forget about this part and up here. It's not a quick process. Go all the way up to the clavicles. This is breast tissue. Okay? You've looked at the nipples, obviously, but you're also going to palpate into the nipple area, and you are going to actually try to express for discharge. Because most discharge doesn't just happen as you're doing a breast exam, you have to express it. And it isn't grabbing the nipple and squeezing. That's not how you express it, okay? It's just like a suckling baby. If they just latch onto the nipple, it hurts like crazy, and they can't get milk that way. So you're trying to express the ducts. And so you actually kind of grab the whole areola and kind of milk it up to the nipple. Okay, so don't just grab the nipple and squeeze. You will not get any discharge out that way. All right, so do both of those. And if you do get anything, put it on a slide.
This is only if they mention they have discharge, or do
No.
we do it regardless?
Yeah, because you may pick something up that they never actually had, so you should definitely. Because you may have a mass within the areola that you didn't feel with your breast exam, and you may have a mass up into the nipple. Because that's part of it, the exam. Okay? Which way you gonna do? It doesn't matter. Just do it the same way every time. This is always the time that I talk about doing self-breast exams. I know there's controversy with it about, you know, who do we recommend, don't recommend women doing self-breast exams. But in all honesty, have patients do a self-breast exam. Okay? Have them do it. There's enough people out there that you probably know, that I know, that found their own breast cancer. I don't care if they found it late, they still found it. That's why they're saying not to do it, because they find it too late, it's already so big. Well, half the women don't go get a pap smear or breast exam, so if they found it now, it's better than them not have gone to the doctor for 5-10 years and it's grown 5 or 10 years and it's all over the body, right? So use this time to have them check and do a breast exam. They don't have to do it monthly, but I say monthly, so I just get them in the habit of doing it. And the other part is so they know their own breasts. Okay? Because they're like, I've heard of this part though. I don't know what I'm feeling for. I said, well, no one knows what they're feeling for. But if you do this enough, you're going to go, I know there wasn't this lump before. And so if they do it monthly, they get to know their breasts. And then if they can do it every 3 months, or when they think about it, they'll know that there wasn't that before. It was not there before. You want to kind of recommend to them to do it the week after they menstruate, because your breasts are tender right before you menstruate, and a lot of times kind of during menstruation. So, because I always say, well, it hurts when I do it. Well, recommend that week after they menstruate. It's less painful. It's not painful, it's just uncomfortable. And tell them what you're doing when you do it. Get to that tail, okay? Did you guys talk about breast disease yet? Benign breast disease? So we have fibrocystic disease, you have fibroadenoma, you have obviously breast tumors. So fibrocystic are benign, it's a benign disease. You'll feel them in breasts all the time. They're real cystic, kind of lumpy breasts. They're movable, mobile, small. They're the ones sent to get multiple mammograms and multiple ultrasounds and fine needle biopsies until they figure out that these are cysts and they're really nothing. You usually see familial, we have them decrease their caffeine intake because it makes them worse. Fibroadenomas are benign. They're a nodule, okay? They don't vary with menstruation. Cancers are hard. They're fixed. You know, not all women have a family history of breast cancer. Hey. Oh. Yay.
Should maybe be easy fix.
Hey, Lord.
We just need
Let me get whatever that is.
Where's the,
I have it here.
oh, try it now. Okay. This gonna work. Oh,
Oh,
this one's working.
yay. Okay. Thank you so much.
Yeah, magic touch.
Just have to look at it critically.
Okay. Sorry.
Gynecomastia is, see this in men, you know, breast development, or we shouldn't have it. This, please, if you smoke pot, don't smoke too much of it, it can cause it. Okay, so limit your pot smoking. This can be from a tumor, pituitary tumor. This can be from, it's obviously from extra hormone. It can be from nothing, we don't know. From certain medications can do this. So breast discharge galactorrhea is how you document it. So one of the other labs you check, especially if it's like a clear discharge to a yellow discharge, is their thyroid. You check the TSH, breast discharge. Okay. Mastitis. You guys, I think, got a little bit of this with Dr. Latassi. Okay, it's painful. That's a red breast. breastfeeding, they're pretty miserable. They're not gonna want you to touch the breast, but you have to look at it. Okay, so the pelvic exam. So you're gonna do a cervical, you're gonna look at the cervix, the vagina, the external genitalia. We will do a bimanual exam to assess the uterus, the ovaries, perineum, a lot of different things. So draping is the most important. So when they're sitting there with a gown that opens to the front and just a drape over their legs, what you want to do is you have them lay back and pull the extension out, and then you'll pull the stirrups out. And then when you get them into the stirrups, what you want to do with that drape is you want to, because I'm sitting here because the patient is laying there and I'm sitting down at this level, right? You want to kind of push the drape down so you can actually see your patient, because it's kind of odd when you're between their legs and they can't see you and you're talking. It's uncomfortable. So what you want to do is establish a eye-to-eye with them. Okay? There's another thing that you need to think about is don't just go to the external genitalia without talking to them, or what we call a little bit of neutral touch. So usually what I do is I'll touch kind of the knee. So I'm going to touch your knee here, and then what I do is I kind of move down the leg, the inside of the leg, so that I'm not just touching the external genitalia and they're jumping off the table and running out the door. So it's what we call a neutral touch. Obviously you're gloving for this part. You do not have to glove for the breast exam unless you want to. Okay? It's about 50-50. Amy, do you breast for the breast exam? Yeah. Most examiners don't that I've ever worked with. There are some that always glove anytime they touch a body. So it's just up to you. I think it decreases my ability to feel. Now obviously if a patient says, I have nipple discharge, or I have a rash on the breast, they've come in for those specific things, then obviously you're going to have to put some gloves on. But if you're just doing a well-woman exam, examining the breast, you don't have to do that. But now you're going to be, right? Obviously never spread the patient's legs forcefully. Thank you. All right, so the first thing you're going to do is you're going to take a look at the external genitalia. It can tell you a lot just by look, because you're looking for lesions. Okay, a lot of STDs give us lesions. Have you had the STD talk?
That's smart.
Oh, well, you get to see lots of pictures, and I've got a few here. But a lot of STDs are externally. Even gonorrhea and chlamydia and trick, you can actually see some discharge coming from the vaginal opening. Okay. You look at the hair pattern. You look at the hair pattern. You want to look for some type of possibly a candidal or fungal rash. Okay. You want to look at the labia majora and the minora, right? You want to make sure there's no swelling in those areas. Take a look at the clitoris. Is it developed normal, or do we have someone who we missed some masculinity, some type of genetic disorder or hormonal disorder? Okay, look at the urethral opening. So you will see this. It's hard to really see the Bartholin's gland, but it's right at the opening. You guys know where it's at, right? Posterior, right at the, kind of the opening there. If you look and you see kind of the labia, there's some type of swelling. A lot of time what you've got is an abscess in the Bartholin's gland, which is associated with an STI. So this is an example of a Bartholin's abscess that has to be drained. So you open it, it drains out, and then you put a catheter in there to keep it open. This is not fun, this is very painful. Look into the perineum and into the anal area. Again, STIs don't just happen in a female in the vaginal area. You can find STIs in the anal area with condyloma, okay, with herpes. Then you have to think past your normal intercourse. People have anal intercourse, both males and females. So that's why we check those areas. Okay, STIs can happen in those two areas. Okay, so we use a speculum. This is a speculum. We have these at the clinic. This is to be used once. Okay, it's plastic. There's also metal ones that they're cleaned and sanitized after every use. But we use this once. There's portable lights that you can use that go over your shoulder. Use those forever. These are nice because they actually have a light that come up, and I can see right down this, so it gives me a light right into the vaginal canal. The lights that plug in and come over your shoulder, you've got to put it wherever you need to look. But the nice thing about these is, I think these are the ones you guys will be using. So, light, reading light. So it goes up into this, and it allows my light to come through there. So it reflects and then goes right into the vaginal area. The other thing is these are great because I have a splash guard. Literally. Don't think you don't need it, you do. It goes down there because I can't autoclave this tube, right, because it's electrical. So we have to protect that from any contamination from vaginal discharge and all that kind of stuff. Okay, so here's my speculum. Now, the nice thing is these aren't metal, so they're not as cold. If you have a metal speculum, a lot of times we have a warming drawer, or you can use warm water to warm them up. Now, you will have this when you're out with preceptors, and they will say that lubricating gel is not to be used, and I bet some of the OBGYNs may say this. Lubricating gel should not be used because it interferes with your chlamydia and gonococcal, and it also can interfere with your cytology when you take your cervical samples. That's not true. All the studies now say that's not true. So I recommend you using lubrication. If you want it with a preceptor and they say don't use this, don't use it. Because they're right, okay? They are right. But if you are practicing someday, because you get through this program and you pass your boards, you can use lubricating gel. All the studies show it doesn't interfere with it. Now, obviously, you don't want to use like this whole packet. You don't have to, okay? But to use, what I usually do is I'll put it on the table. I'm not really on the table. What I'll put it is on a tissue or a napkin and put a little bit there, and just kind of place a little bit on there. You just need a little bit. Okay? I don't have to lube it up. So you just place enough on there to get it so that it moisturizes the area to allow the speculum to enter easily. If you don't have lubrication or you're with a preceptor who doesn't allow it, which you will need it. I don't know if it's 50-50 now or whatever. just take warm water and use that to lubricate your speculum. Okay? Either way is fine. Oh, I got lube everywhere. Okay? What you're going to do is you're going to open up the labia minora and majora, okay? But it's the minora that you have to get opened up. Some women, or some practitioners, sorry, will do it this technique this way, okay? I do it with my hands this way. And the reason I do it this way is because I don't like to put my hand up here. There's a reason for that. Could you guess? The clitoris is up there, okay? The clitoris is up there. The urethral opening is there. And those are the two most sensitive parts of a female. So you can do it this way as long as you avoid those areas and put them in between that. But if you're up here and you open it and you hit the urethral opening, it's painful. The urethral area is very sensitive. So if you do that, I don't care which way you do it. Just be cognizant of those areas have a lot of sensitivity and nerve sensation to them. Okay? So as I open the area, you take a look at the enroitus and everything. And by doing that, I also can put a little bit of pressure at the posterior aspect of the enroitus and the vaginal opening. Because what happens is, as I insert that speculum, what happens is you get a little vagismus. It's spasm of the vagina. And so if I put, I need a towel.
There's paper towel right there.
Oh, okay. So if you put a little posterior pressure on the vaginal opening, you push it down a little bit, it'll cause that initial vagismus to relax, and then you can insert the speculum. Okay? So, as I open, okay, you're going to want this at about a 45, okay? Don't be completely like this. Some people will teach you that. The reason you don't is because this opening, if it's not quite shut or as you're kind of unsteady, you can pinch the top of the anterior opening and even the urethra. So you don't want to do that. So if you put it at a 45, if it's a little bit open, it's not a big deal. But it's completely closed, okay, at about, again, out there. You want the angle slightly downward, okay? And I am going to, here is my vagina. You're going to see my vagina. Okay, so as I go in, okay, I am going to go in and I'm going to insert this the whole way. Do not open this until you have put this all the way in. There's a reason for that. Because as I'm coming in, the cervix is tipped like this in most women. So the cervix is here's my tube, my vagina, and the cervix is down here. If I come in and I'm not all the way down here, okay, can everyone see this? Kind of. If I open it too soon, I will just kind of take up half of the cervix. Make sense? If I go all the way in, when I open this, it will pop my cervix in. So I'm here, I'm all the way in. As I open, it'll pop my cervix in. Does that make sense? Did everyone see that? If you did, just raise your hand because I'll show you my cervix at your angle. Because that's the biggest mistake. What happens is you go in, you think you're all the way in, and it's about right here. It's about right there. And you open it and you go, I can't find the cervix. I can't find it. I'm like, yeah, I know. Close your speculum and put it all the way in. Okay? That's the biggest mistake that most people make, because they get so excited and they sound like this. And they get down in there like, really, it looks like that the first time. So, keep it closed. Actually, the way I keep it closed is I actually put my hand right here, and I put it all the way in, okay, and then I just open it up. So I can't find the cervix, you can kind of close it, right? I can control this, I can kind of close it, and you may have to kind of move it a little bit to try to find the cervix. It's gonna happen. Let's say you try and try and try. I cannot find the dang cervix. I have looked, and there are people I have looked and looked, I can't find their cervix. Thinking, well, maybe they don't have the cervix. They have a complete hysterectomy. So one of the techniques you can use is to say, I'm having a hard time finding your cervix. So I'm gonna take out the speculum and I'm gonna do a bimanual exam. So take the speculum out and do a bimanual exam and actually find their cervix. Because it may be to the right, maybe to the left, it may be that it's anteroverted, so the cervix, instead of sitting, so here's our uterus and the cervix is down here, their uterus is actually kind of like this and it's sitting up high. And it's just a cervix that's sitting upwards because their uterus is actually laying posterior. Remember, our uterus sits anterior, so our cervix sits down.
Do you how many hand fingers do you put do bimanual?
2.
Two.
Yep.
Bimanual.
Your second and third digit. Yeah, that's a good question.
We talked about doing sterile speculum exams in the second and third trimester and not doing bimanual, if there's bleeding. What makes the speculum safer? If you're not opening.
I'm not an OB.
What you're doing is you're not sticking anything directly towards the cervix. When you go with the speculum, it typically does not cause any trauma to the cervix. You're looking as you go in, especially with the lighted cervix, like with the lighted speculums. So when you're doing it blindly and you go in with fingers, you can go too far, you can dilate the cervix, you can rupture membranes. With a speculum, you're not doing that because you're visualizing the whole time you're going in.
So you can see even without it open?
Yeah.
Oh, okay.
Yeah. And you can actually, once you kind of get in, you can actually open a little bit. It's just that you don't want to get this opened up halfway down.
Okay.
Because actually, they're looking to find the cervix pretty quickly. Because all they want to do is visualize the cervix, see if it's open or closed. Okay, so next issue you might come across is someone who is very obese or has lost a lot of the musculature in the pelvis. Or they have a lot of prolapse. So you get in there and you open up that speculum and the vaginal canal kind of collapses. So as this opens up, tissue just, and I can't see. And that does happen with, you really see it a lot with obese women or women who've had a lot of babies, a lot of vaginal deliveries, okay? So one of the things you may have to try is a bigger speculum, because there's different sizes. If that doesn't work, to keep that tissue out of the way so you can visualize that cervix, is what you can do, and I forgot my glove, is actually to put a finger of the glove over this, okay? You cut the tip off, or cut the tip to begin with, put the glove over that, and so as I open it, I've got the latex or non-latex gloves now on each side to keep that tissue out of the way. That makes sense? Which had a glove? I forgot a glove. And I've had to use that technique a lot when we worked in this. Because we have just a lot of women who've had lots of babies. So this will happen to you. Remember that, keep that in your pocket. It will happen. Okay? That's different positions of the uterus. Okay, so you've got the cervix. You're looking for discharge coming out of the cervix. You're looking at the surface. Most cervix are nice, kind of a pink color. They're very smooth in comparison to the vaginal wall. It's definitely a different texture than the vaginal wall. That's how you'll know what it is the first time you see it. Be like, that definitely has a different texture to it. The shape of the opening, the cervical os. Okay. So as women have babies, did you guys learn this one already? The os opening, different. So the picture there is, right? So that's someone who's not had a child. This is someone who's had a child or a few. It's different. So then you take a pap smear. And what the pap smear is taking cells within the os and right on the outside of the os, the cervical os, right? And you have, I don't have the older paps that we used to do with the cytology, but you want to make sure, this is nice because it's, I'm gonna get a picture here. And I'll come back to this. But this is a brush that collects both endo and ectocervical cells at the same time. So you go put this within the os, right, within that os. This is my tiny little os now. Now you see my os. So what you're going to do is you twirl this between 3 to 5 times, okay? And that's my collection for my pap smear. I open this up, okay? And nice thing is this actually just pops off and goes in there, and you send this whole thing off for the pathologist to get the cells. It's done. Okay? There's also a little cervical brush and a spatula. So the spatula you use that goes, you take the brush and you twirl it back and forth 5 times, okay, within the os. You use that in a collection cup, and you put it in there, and you twirl it back and forth, okay? Use a spatula and you go around the cervix. There's a longer area of it. Dang it, I forgot that in there. And you'll go and you'll swirl around the cervix, back and forth, to get those cells. And you can put in this and then scrape it, okay? Not very often, but there used to be where you'd put it actually on a slide, and you'd go back and forth and fixate the slide, which Dr. Anyone's doing anymore that I know of.
Yeah, they don't, we need to sign.
So the spatula, the endocervical, the ecto is the brush. Okay? Now, most women will spot after a pap smear, especially if you hit the os. So just warn them about it, that spotting is normal after a pap smear. I always set out a little thin pad for them, or the nurse does that for you, and so that they can put that on, a little panty liner. And tell them that may happen and not to worry about that. Okay? At the same time, you can collect your gonorrhea and chlamydia. So that goes within the cervical os. So it's a little Q-tip here. And it does both, gonorrhea and chlamydia, nicely. And it's not just an in and out. You should actually hold it there, back and forth, for about 30 seconds or so.
Is this through the speculum or?
Yep, right through that speculum. I am. Right there.
Yeah, I get it.
Okay? And then what you do is you put it into your collection, and this actually breaks off. And then you send that off. Obviously, it's labeled the patient's name, birthday. You can also check for trick. Okay? You can check for BV, bacterial vaginosis. You can check for fungal infections by taking another swab of the vaginal discharge around the os and everything. So you just take another sample. Okay? You can take a slide, right? And you put it on. Put a cover slide on. And you can look under the microscope, right? Or if I don't have time to look at the microscope right then and there, because my patient's up there, what you could do is you can use a little saline swab. Your nurse is holding that, you put it in there. Set it there. Well, after you're done with the patient, then you can take this, put it on the slide, and look under the microscope. So what I'm looking for is, I'm looking for trick, which is little flagellated football-shaped protozoans that I always make this. I always tell my nurse, do they have these things? And I usually come out going, without the microscope, at least. Pretty great, if you ever see it. You have to do it pretty quickly, and actually, sometimes you have to actually wait for the microscope to warm it up. They become a little more active. Okay? Or do they have clue cells? Do those epithelial cells have specks in them? I always call it a dirty epithelial cell, because that's what it looks like. Okay? So then you can add KOH, and if you want, you can do the whiff. Does it sort of nasty, fishy odor? You can do that. And then you can see as it lyses the cells, you have fungal. Do you have micro? Is there candle fungus on there? That's kind of fun to do. So you just put on the slide, put a drop of that stuff under the cover slide, and you look under it. I do that on my rotations all the time because most family practice does their own. So you'll learn to do that, it's fun. Okay. The other thing you can do is, of the discharge, for a well woman exam, or actually if someone's coming in for discharge, is you can actually pH their discharge. And to be honest with you, the only thing I think of is if it's basic, it's like 7, I think, it's BV, it's bacterial vaginosis. All the other discharges are 6 or below. So usually it's just BV, so I'm looking for anything that's like 7. So you just dip it and you can read it. It's got the whole thing on there. It's really pretty easy. So it's a quick little test. We don't use it very much, but it's probably a great thing to do if it's just a quick thing. You take their discharge and just do it if it's above 7 or above, then it's BV. Okay. Females with discharge, you should do a vaginal gonorrhea and chlamydia swab. Don't do a urine. Just don't do it. Just don't. Okay, so your bimanual exam. So you're obviously gloved, right? And you're going to use KY. You're going to put on your 2 fingers. Make sure you talk to the patient. That what you do is you're going to, you're going to do a bimanual exam, which is you're going to place 2 fingers within the vagina. Okay? You're going to put your other hand on top of their, kind of their pelvic region, and you're going to push down. Usually what I say is what I'm feeling for is to make sure that uterus is normal in size. Make sure I'm not feeling anything that's abnormal, any